Healthcare markets are distinguished by a persistent tension between necessity and scarcity. Unlike ordinary consumer goods, medical services are often demanded under conditions of uncertainty, urgency, and limited patient knowledge. This asymmetry alters the conventional interaction of supply and demand and renders the healthcare market a carefully regulated domain rather than a fully self-correcting one. Demand in healthcare is not driven solely by preference. It is shaped by illness, injury, demographic aging, and technological possibility. Patients rarely choose whether to enter the market in the same voluntary manner in which consumers choose entertainment or clothing. Instead, the onset of symptoms, chronic disease, or preventive needs creates a derived and often inelastic demand. As a result, even substantial price increases may not cause a proportional decline in utilization, particularly when treatment is essential. Supply, by contrast, is constrained by the lengthy formation of medical labor and the capital intensity of infrastructure. Physicians, nurses, laboratories, hospitals, pharmaceutical producers, and diagnostic networks require extensive training, licensing, and investment. These barriers mean that supply cannot expand quickly in response to sudden changes in need. In emergency conditions, the inability to increase supply rapidly becomes especially visible, producing queues, rationing, and political pressure. Information asymmetry further complicates market behavior. Patients generally lack the expertise to evaluate diagnosis, quality, or necessity with the same precision as providers. This creates a principal-agent relationship in which physicians and institutions make decisions on behalf of those who bear the cost. While professional ethics mitigate abuse, the imbalance can still generate overutilization, underutilization, or uneven treatment depending on incentives, insurance design, and institutional norms. Insurance profoundly reshapes both demand and pricing. By reducing out-of-pocket costs at the point of service, insurance lowers the marginal price faced by patients and can increase consumption of care. At the same time, insurers negotiate prices, manage risk pools, and introduce utilization controls to prevent expenditures from rising without limit. The result is not a pure market equilibrium, but a mediated system in which administrative rules, reimbursement schedules, and coverage policies influence outcomes as much as patient choice. The medical market, therefore, exhibits a paradox. Society expects healthcare to be both a right and a commodity, both compassionate service and economic transaction. When demand rises because of epidemics, aging populations, or new technologies, the inadequacy of supply becomes visible. When supply expands through innovation or policy support, access may improve, but expenditures may also rise. Economically, healthcare is defined by the difficulty of balancing efficiency, equity, and quality in a sector where the consequences of failure are measured not merely in money, but in human life.